Today we are going to continue talking about the clinical pharmacology as a part of endocrine pharmacology. We are going to continue talking about the reproductive male hormones. I am Dr. Khalid Hassan, professor of clinical pharmacology and drug therapy. So as you can see here in this slide presents the androgen, so the main hormones in male. In male, we have the androgen. The androgen considered belong to the steroid. Number one. Number two, androgen has two main function in the human body. Number one, androgenic effect, sexual effect, and anabolic effect, masculinizing effect. The masculinizing effect may be active in both male and female. Testosterone you consider like the most significant androgen in a human. Also, they found that testosterone, the main location of secretion of testosterone, the main organ responsible for testosterone secretion is Leydig cells. So Leydig cells, the main source of testosterone, the major amount of testosterone produced from the testes and from Leydig cells. We have smaller amount produced from the ovary and the adrenal gland. In this slide here, if you look on the right side here, what we have, they said the testes produce the main hormone testosterone. We have a smaller amount of dihydrotestosterone and androstenedione. On the other hand, the adrenal gland, so we know that adrenal gland available in both male and female. Adrenal gland produce several androgens, such as dihydroepiandrostenedione, DHEA. Then we have dihydroepiandrostenedione sulfate, DHEAS, and then we have androstenedione. So the situation here, if we ask the question, what is the primary androgen produced from the adrenal gland? So we have three main androgenic hormone produced from the adrenal gland. We need to remember we have DHEA, DHEAS stand for sulfate, and androstenedione. All these hormones are androgen produced primarily from the adrenal glands. So they tried to remind us we have some combination between adrenal gland and testis. They said androstenedione produced also from the testis and ovary. Okay, this slide here present the function of androgen. What are the functions of androgens? Number one, the androgen responsible for primary male sex hormone. It's like number one, it's like consider the main sex hormone in male, the androgen. And androgen is important for the male maturation, responsible for spermatogenesis, which means sperm production. They found androgen also play important role in hemoglobin synthesis and muscle synthesis. Androgen or testosterone also play important role in bone resorption prevention. So androgen or testosterone prevent osteoporosis, but we don't prefer to use testosterone as a prevention or treatment of osteoporosis due to the risk of masculinization in female. So in this case, it's not considered like first choice for for a woman suffer from osteoporosis. We have alternatives such as bisphosphonate, for example. Okay, then we move to the synthetic. This is a normal androgen. We have testosterone in our body. Then they move and they produce something called synthetic modification, synthetic androgen, and we have several type of synthetic androgen. What they have done, they modified the structure of androgen. When they modify the structure of androgen, this lead to the modification, change in solubility and susceptibility to the enzymatic breakdown. And that mean this medication will be able to prescribe it orally, because testosterone will be destroyed in the GI system by the enzyme, and they develop synthetic androgen, synthetic testosterone that resist breakdown by the enzyme in the GI system. Number one. Number two, the advantages for number two here. Another one for number two here. They said we make like synthetic. We make synthetic androgen with long half life. This is another advantage. So the first advantage, the synthetic androgen become maybe change and more soluble and less synthetic, susceptible to the enzymatic breakdown. This enzyme, this medication, new medication, has a long half-life. They were able to separate the activity between the anabolic and androgenic effect. So what that mean for us? They have now in the as synthetic androgen, they have some androgen with a separate action of anabolic. So we call it anabolic estrogen, anabolic testosterone, and then we have separate androgen with the androgenic effect. So we are going to speak about this one according to the structure of the enzyme. Okay, moving to the now we need to speak about the pathway of testosterone in Leydig cells and other cells. As you can see here, the main source of testosterone, this is the testosterone at the end. So the main source of testosterone coming from the cholesterol. Then we have several enzymes. For example, we have cytochrome 11A, then we have cytochrome 17A, then we have 3-beta hydroxylase. So all these may be enzyme involved in synthesis of testosterone in the Leydig cells, starting from cholesterol. So this one here show you like a simple diagram about the synthetic of testosterone. Start from cholesterol. Cholesterol will convert to the pregnenolone by the action of enzyme. Pregnenolone will convert to the progesterone. Progesterone convert to the 17 alpha hydroxyprogesterone. Then the hydroxyprogesterone convert to the androstenedione, and the last step will be androstenedione convert to the testosterone. So you can see here the chain of the reaction. We start from cholesterol until we have testosterone. And we have some, maybe this website here. If you click on the website, they will take you to the, okay, so this is the website here, and let me show you what we have here for the website, only to show you the graph. You can see the graph here. This start the testosterone. This is the testosterone here, and testosterone start synthesized from the cholesterol, pregnenolone. Pregnenolone, we have two pathways, and then we have enzyme responsible. Okay, how this medication, how this hormone work, the six hormone work. They said in the muscles and liver, the androgen in the muscle and liver, testosterone the main hormone. So in our muscle and liver, testosterone will be the main hormones, and they act. The testosterone acts on the nuclear receptor. So for more detail about this action here, it's very similar, mimic the action of estrogen. Okay, let me do something here. Okay, so what they said here, we have the testosterone work on the nuclear receptor, mimic the action of estrogen. So I recommend I recommend you to review the estrogen lecture with more details about nuclear action of estrogen, its mimic effect of the testosterone. So here we need to remember testosterone work on the receptor called nuclear receptor. That means the receptor will be available inside the cell, intracellular receptor or nuclear receptor. Okay, another issue here, some tissues have different type of testosterone, such as prostate, seminal vesicles, epididymis, and skin. They found these organs, these small tissues, has different type of testosterone. This testosterone called dihydrotestosterone. How this tissue get the testosterone? These tissues have the enzyme called 5-alpha reductase. So these tissues, when we have testosterone in our body, when we have testosterone with the 5 alpha reductase. This is to show convert testosterone to the dihydrotestosterone. So what is the main hormone in the prostate? Dihydrotestosterone. What is the main hormone in the epididymis? The dihydrotestosterone. What is the main hormone in the skin? Dihydrotestosterone. What enzyme responsible for conversion of testosterone to the dihydrotestosterone? We have 5 alpha reductase. So this is an important concept we need to remember. Other sources they said that dihydrotestosterone 4 times more potent than testosterone. Please remember the most potent testosterone in human body, dihydrotestosterone, not the testosterone. Okay, the purpose of this slide here. So what is the purpose of the slide here? As you can see, the slide here represent the supervision of the hypothalamus, represent the supervision of hypothalamus and the anterior pituitary on the sixth organ, and what we have here, testes. Okay, so what we have, the hypothalamus produce the GnRH, gonadotropin releasing hormone. Gonadotropin releasing hormone stimulate the anterior pituitary to release LH and FSH, and LH will stimulate here we have male. The LH will stimulate the testes or stimulate the testes to produce the testosterone. So the main hormone produced from the anterior pituitary will be LH. LH will stimulate the testes to synthesize and release the testosterone. On the other hand, we have FSH here from the anterior pituitary. FSH also stimulates the testes, and the purpose here to increase or stimulate synthesis and release spermatogenesis. Here we need to remember in male, FSH responsible for spermatogenesis, responsible for synthesis and release of spermatogenesis. LH responsible for production of testosterone. So the question now, which anterior pituitary responsible for stimulation of and release of testosterone? LH. Which of these male hormone produced from the anterior pituitary and responsible for spermatogenesis? FSH. We need you to remember this equation here, this case here, this axis here. Okay. Now what we have here, we have something called negative feedback. You can see the negative feedback here. Testosterone practice negative feedback. What that mean for us? So you can imagine here you have a patient and you prescribe androgen to your patient, and the androgen already in his body, and when you prescribe androgen from outside, from exogenous androgen, that mean the androgen level in the human body will be high. So when you prescribe androgen in a human body, the androgen will increase. So we have increased amount of androgen in a human body. When we have increased amount of androgen in a human body, this will practice something called negative feedback on the hypothalamus and pituitary. And you can see it here, I will repeat it, you can see it here on the graph. So the axis or exogenous androgen will practice negative feedback on the hypothalamus and pituitary. This will lead to decreased release of gonadotropin. This will lead to the decreased release of FSH, and LH will be decreased. So decreasing FSH and LH, this will also decrease reproduction of testosterone. So decrease production of testosterone, and this will lead to the decreased testicular progesterone production, and we have consequences result. We are going to discuss it in the next slide. So we need you here to remember the physiological action and the pathophysiological action for the treatment. This is the most important image and chart for us, or flow chart for the testosterone pathway. So for roughly here we have 90% of the testosterone pathway affect the androgen receptor, and this androgen receptor is responsible for the internal genitalia effect, skeletal muscle effect, erythropoietin, and growth, bone growth. So this one in mainly affect the male, okay, and this one we have male and female for the estrogen. And then we have, if you remember that, if you go back in the skin and the prostate, we have enzyme called 5 alpha reductase. 5 alpha reductase convert testosterone to the dihydrotestosterone. Okay, dihydrotestosterone affect the androgen receptor. Dihydrotestosterone responsible for external genital differentiation during gestation, responsible for maturation during puberty, responsible for prostate disease, for hair follicles, increased growth during puberty. So, which hormone is responsible for hair production or hair growth? We have dihydrotestosterone, prostate, dihydrotestosterone, maturation during puberty, dihydrotestosterone. Moving to the next maybe pathway. So the first pathway, like direct convert testosterone to the to like remain like androgen and affect the androgen receptor 90%, and this is 2%, 10% divided by dihydrotestosterone and estradiol. We have enzyme called aromatase. Aromatase responsible for conversion of testosterone to the estradiol, and this is mainly happen in female. Okay, this mainly happen in the female. If you go back and review the lecture about reproductive female hormones, so testosterone convert to the estradiol by the enzyme called aromatase. The estradiol bind to the estrogen receptor again. Estrogen receptor considered like nuclear receptor. Okay, so the estrogen receptor affect the bone, increase bone density. Also, if you prescribe this hormone, this hormone responsible for libido, and this hormone may lead to the epiphyseal closure. So we have the three pathways. We need to remember these pathways. Testosterone. We have the main one. Testosterone will affect the androgen receptor directly, 90%. 10% will be between aromatase, estradiol, and 5-alpha reductase dihydrotestosterone. Uh, Again, we have this one here covered in the female hormone. As you can see here, we have anastrozole. Anastrozole inhibit the enzyme, inhibit aromatase enzyme, prevent formation of estradiol, decrease estrogen in human body, and the indication for decreasing estrogen in human body mainly related to the cancer, endometrial cancer, or breast cancer. So anastrozole used for breast cancer, advanced breast cancer, anastrozole. This medication already covered in the reproductive female hormone. I refer you to that lecture. And on the other hand, we have two medication inhibit the enzyme called 5-alpha reductase. 5-alpha. We have finasteride, dutasteride, afodart. So finasteride, dutasteride inhibit 5-alpha reductase and prevent formation of DHT. Therefore, we use this medication for patients from benign prostatic hyperplasia. So as you can see from this pathway here, we have two options to intervene. The first one, a medication used for breast cancer. We have aromatase. The question, how the aromatase work? Aromatase inhibit the enzyme called we have anastrozole. Anastrozole, how the anastrozole work? The anastrozole inhibit the enzyme called aromatase, prevent formation of estradiol, and this medication used for advanced breast cancer treatment. On the other hand, two medications such as finasteride and dutasteride inhibit 5-alpha reductase and prevent formation of dihydrotestosterone. We use it for the treatment of benign prostatic hypertrophy. If we use it like small doses of finasteride, we use it for male pattern baldness, for example. Okay. Therapeutic uses. The first one, FDA approved. We use testosterone for androgen Deficiency, if the patient suffers from hypogonadism, could be primary hypogonadism, could be primary hypogonadism or secondary hypogonadism. So we have it there. So this is the main reason we use it. FDA approved. Hypogonadism could be primary or could be secondary hypogonadism. This is approved by the FDA. This one here considered like off-label, and could be, we could use it for anabolic steroid, or we could use it for, in athletes. You can see here unapproved use anabolic steroid to increase lean body mass, increase muscle strength, and enhance performance in athletes. So please remember the main clinical use of androgen to treat patients from primary hypogonadism or secondary hypogonadism. Pharmacokinetic, from the pharmacokinetic, we are going to have the medication name there. We need you to remember the highlight, the blue highlight you can see here. We don't have testosterone oral. We don't have testosterone oral because if you prescribe testosterone oral, testosterone is ineffective, will be inactivated by the first pass metabolism. We don't have oral testosterone. Alternative, we have batch, we have gel, we have solution, we have buccal tablet, we have pellet for implantation. Okay, so for the testosterone, we have injection with testosterone esters, we have injection, we have testosterone subunate, this medication prescribed intramuscular, testosterone subunate. Then we have testosterone enanthate subcutaneous. So please remember, for the testosterone, we have testosterone ester, and both of them is like the first one subunate prescribed or given injectable, intramuscular injectable. Then we have subcutaneous testosterone subunate. Moving to the other, they developed the synthetic testosterone, and they modified, and the testosterone become available orally. So we have testosterone orally derivatives. We have methyl testosterone, fluoxymistrone. So methyl testosterone, fluoxymistrone. This is mainly testosterone and available oral. Then they found them something. We have dihydrotestosterone derivative orally medication. So orally, dihydrotestosterone active derivative, we have oxandrolone and oxymethylone. Okay, so this medication mimic the action of dihydrotestosterone. That means mainly work on the anabolic as anabolic action. So you can see here this medication has anabolic action. For example, they try to remind us oxandrolone has activity 3 to 13 times more potent than testosterone as anabolic agent. So which of the following considered like most potent anabolic agent? Oxandrolone. Okay, I will go to the slide here only to show you what we have here. Oxandrolone, maybe you can see here, it's like more potent as anabolic compared with the testosterone from 3 to 13 times. Oxandrolone, consider this one considered like the most potent anabolic androgen. Okay, so the purpose of the slide to learn, remember, understand that we have the first two medication considered oral, and you can see here we have capsule, this one oral. Okay, this one oral, and methyl testosterone oral capsule, 10 milligram. Then we have fluoxymistrone, androxy oral also, and tablet. So this we have oxandrolone with available oral 2.5 and 10 milligram tablets oral. So we have three medication available oral. I will repeat it: methyl testosterone capsule 10 milligram, fluoxymistrone tablet 10 milligram oral, oxandrolone tablet 2.5 and 10 milligram. Okay, then we have testosterone subunate. You can see it here in injection, and this medication prescribed intramuscular and belong to the C3 controlled substances. Okay, then we have Xiosted testosterone enanthate. Testosterone enanthate. It's like prescribed like an injection. And this is a medication prescribed subcutaneous, and it's coming like auto injector. You can see the image here, like auto injector. So let us click on the one of these and go through the information, drug prescribing information. Okay. So this one here, the methyl testosterone, you can see we have the capsule 10 milligram here, and we have the chemical structure, clinical pharmacology, how this medication work, um, this medication, the indication for this medication, for the methyl testosterone. You can see the first one, primary hypogonadism, could be secondary, could be congenital hypogonadism. So we have it in male and female. Sometimes we use it in female. Androgen may be used secondarily in women with advanced and probable metastatic skeletal mammary cancer, that we're talking here about the breast cancer. But this is not the first choice. For example, for the breast cancer, we have tamoxifen, we have anastrozole, we have fulvestrant. So we have several medication for breast cancer, not the first medication. But if the breast cancer, advanced breast cancer, is unprobable breast cancer metastatic, we can use it. This consider like this medication, the methyl testosterone, could be maybe option on the table to use in patient with the advanced breast cancer. Okay, so methyl testosterone. Next we have fluoxymistrone, and this one tablet 10 milligram. And this one published on the drugs.com. You can see it here. We have androxy prescribed, and the the generic name fluoxymistrone, and the brand name androxy. If you like, you can click on the, for example, indication and usage. You can see here that we have similar situation, very similar. We have primary hypogonadism, could be congenital or acquired, or it could be secondary hypogonadism related to the pituitary. And the same situation, we can look on the delayed puberty here. We don't have enough testosterone, we can prescribe it as the replacement therapy here. Okay, next one we have oxandrolone. If you click on the oxandrolone again to learn about the oxandrolone anabolic agent, try to bring this to the screen here and describe it to you what we have. If you maximize a little bit and try to understand what we have, oxandrolone, you can see it is available as a tablet 10 and a half and 10 milligram. Indication oxandrolone, normally we use it for off-label for the bodybuilder. Okay, we have used it as off-label as bodybuilder, but what about FDA approved? Normally, oxandrin or oxandrolone indicated as adjunctive therapy to promote weight gain. So keep that in your mind, and we need to remember oxandrolone available tablet 2.5 and 10 milligram. And we have all the information here. You can read the warning. For example, the important issue with the warning, that testosterone may cause liver toxicity. This one very important to keep it in your mind. Okay, I will close this one here. I'll go back again. For the oxandrolone, it's like we have 2.5 and 10 milligram. Testosterone subunate injectable, if you and this one available like single dose vial. You can see here we have 200 milligram. Again, it's like C3 controlled substances. If you click on this one here, only to show you what we have again. Okay, try to bring this here and read the information, data for this information here. So we have testosterone subunate injection, intramuscular use. Testosterone subunate injection indicated for testosterone replacement therapy. Here we talk about the hypogonadism. So if you click on the testosterone subunate and make a copy and put it here, okay, and you can see the image here. We have vial for testosterone and For the image here, you can show you the testosterone available like a vial for injection. Testosterone subunit 200 milligram intramuscular and considered like controlled substance category 3. The last one here we have testosterone enanthate and available at auto injector, and this medication prescribed subcutaneous, more flexible, easy to use, uh, zero point 0.5 milligram, zero point 0.5 milliliter of street solution. We have the auto injector there. Again, similar situation. If you click on that, they will take you to the clinical use of this medication. Again, we try to maybe focus on the information here. Approved 1953, is more than 70 years now. In the practice, Xiosted, testosterone enanthate, available like auto injector. Again, we have the risk of the liver disease, heart disease, increased risk of blood pressure here. So looking on the indications for the Xiosted testosterone enanthate injection as an androgen indicated for testosterone replacement therapy. Here we talk about hypogonadism. Okay, so we already maybe share with you the information leaflet about methyl testosterone capsule, fluoxymistrone tablet, 10 milligram both. Then we have oxandrolone tablet, 2.5 and 10 milligram. Testosterone subunit intramuscular injection. Then we have auto injector testosterone enanthate. Okay, we have oxandrolone, and you can see from the information leaflet the main use to promote gain weight in patients who suffer from weight loss due to the extensive surgery, chronic infections, severe trauma, or we can use this medication to maintain weight or to oppose the protein catabolism or to relieve bone pain combined with osteoporosis. So you can see here this medication mainly focused to enhance and promote weight gain in patients from chronic disease. We have risk of drug abuse by the athletes. There is a risk of dependence. Oxandrolone classified as controlled substance Schedule 3 according to the Anabolic Steroid Control Act of 1990. Okay, we discussed this one here. We need you to remember testosterone has androgenic activity and anabolic activity 1-1. So then we have fluoxymistrone, 1 for androgen, 2 times more potent than androgen as anabolic. Then we have oxymethylone, 3 times more potent as anabolic compared with the testosterone. Okay, which of these medications is like 13 times more potent as anabolic estrogen? We have oxandrolone. Okay, this is a most important maybe topic or subject need to be covered. We need to ask ourselves what are the adverse effects of androgen. Speaking about male, we have priapism, we have impotence, we have decreased spermatogenesis. So when you have decreased spermatogenesis, this may explain, for example, infertility in male because we don't have sperm. So when you prescribe testosterone from outside sources, exogenous testosterone may decrease spermatogenesis and lead to the infertility. Gynecomastia, then we have stimulation of prostate growth. So we don't recommend to prescribe testosterone to the patients from benign prostatic hyperplasia. It's not recommended because the androgen stimulate prostate growth. This is in male. Adverse effect in female. When you prescribe testosterone to the female may suffer from, complain from acne, growth of facial hair, deepening voice, male pattern baldness, exogenous muscle development. Here, if you remember when the people go to the gym to build their muscles, if they take testosterone, oxandrolone, there is excessive muscle development. This is a good result, but we have some negative results such as acne, growth, facial hair, deepening voice, and male pattern baldness, and there is a menstrual irregularity. We need to compare benefit and risk ratio of using the androgen in female. Okay, moving to the children. If you prescribe androgen to the children, this will lead to the abnormal sexual maturation, premature closing epiphyseal plate, and this will lead to the short statures. Um, General effect, this is very important. What they found there, androgen increase LDL, the bad cholesterol increase LDL, and that means there's an increased risk of angina or myocardial infarction, clotting, atherosclerosis, increase LDL, the bad cholesterol, and lower HDL. So here we have to put a question mark if the patients are from cardiovascular disease, atherosclerosis, cardiovascular disease. We don't recommend to use this medication. We can say in another way, androgen increased risk of atherosclerosis, cardiovascular disease. Okay, also they found testosterone increase of risk of fluid retention leading to the edema. Estrogen also stimulate the reproduction of hemoglobin, could lead to the erythrocytosis. For this reason, here we need to monitor the complete blood count for the patient before start treatment with the testosterone. So two things should be take in consideration. Number one, cardiovascular disease, because this medication increase level of LDL and decrease HDL. The second one, speaking about erythrocytosis, we need to monitor the complete blood count to be sure there is no risk of the erythrocytosis. This will conclude our topic about androgen. The next topic we are going to speak about anti-androgen and benign prostatic hypertrophy. Thank you so much for your watching and have a great day.